Yes, sure. Sorry about that. Thank you very much. I was just thanking the organizing committee for having invited me to this conference. I'm honored to be part of this panel, high-level panel. I feel honored and humbled as I've been introduced today. I will discuss a study developed at the Universitari de Catalunya Hospital, Prevalence of Genetic DAO Deficiency in Newborns. I've been given 20 minutes, and I'll try and explain current situation of DAO deficiency in newborns and infants and children. It's quite a long presentation. I will stick to 20 minutes. If there are questions, I'm open for questions during the discussion. I will just share the DAO data that I think are most interesting for today. As you know, there are different tissues that synthesize DAO. I'm most interested in enterocytes. As you all know, adult patients, it seems that the levels of plasma DAO may be correlated with the maturation and integrity of the intestinal mucosal membrane. And as a neonatologist and pediatrician, I should like to know whether this is also applicable to newborns. As you all know, there are lots of associations, as we've heard throughout the day, focusing on the activity of this enzyme, and physiologies and disorders that are still being developed to see specific relations and associations for every disease. All previous speakers have explained several studies. In any case, it seems DAO has a potential value as a intestinal damage marker. But before moving into that, let me introduce you to another type of tissue, placenta. As a neonatologist, I'm very much interested. You know that DAO is produced in high amounts by the placenta, and the scenario seems to be that this large amount of DAO synthesized by the placenta creates kind of a metabolic barrier that prevents excessive entry of histamine from the placenta. It seems histamine in the placenta, because of the toxic activity, the fact that it can differentiate and its own cell growth capabilities, may be damaging for the fetus. It could be harmful. Still, it's not clear because it's still being researched, but it seems that the fact that the placenta secretes such high amounts of DAO may be having a protective effect, protecting the body from the fetus's body from the amine. And this study is from 2008, is a criticism of a previous review that I found very interesting. And these researchers, what they did was the following. They studied DAO deficiency and the impact on pregnant women. And they see there is a high risk of having high-risk pregnancies. So there are complications during pregnancy, such as gestational diabetes, premature delivery or rupture of membranes. Very useful. Lower DAO levels might have an impact here, especially for women with histamine intolerance that have been diagnosed. It seems they endure many more complicated pregnancies, such as miscarriages. It has to be assessed, still being developed, but it's interesting to bring these results here. And why am I summarizing everything regarding the placenta? Well, in rats, if there is less DAO in circulation, in the blood flow, it might have to do with the maturity of the intestinal tissue in these newborn rats. But this is applicable to human newborns. It would be very interesting to know the degree of maturity of the gut in newborns from that data. There's just one study from 86 where they try and look the level of DAO in newborns. Is this one here? And as you can see, the n is very small. What researchers did was measure circulating DAO in pregnant women and 33 newborns. And this is very interesting, and it has to do with the placenta. They realized that in pregnant women, DAO levels, circulating levels, were very high compared to other adults. And so they associated it with the fact that there might be leakages, DAO leakages from the placenta into the maternal blood flow. And the same happens with newborns. They realize that for the first day of life, there were some levels that were significantly higher compared to the levels that would assess for the seventh day of life. And the explanation was just the same as with pregnant women. For newborns, there's higher levels of circulating DAO because it seems there is a leakage that has been leaked from the mother's placenta, to an extent where there's this other piece of data that is very curious, and is that the reduction of DAO during the first days, day 1 to 7 after birth, well, it's a progressive decline. There is no point where there are more catabolism, is just progressively declining. So the question that I asked, well, this can be interesting for neonatologists. Can we use DAO blood levels as a marker, as a determinant to understand whether there is a risk of NEC in newborns? Well, it doesn't seem to be, well, should not be used. As I said, this is a study with a very small n, but it seems that due to the large amount of maternal DAO found in newborn circulation or blood flow, any change in DAO because of the immaturity of the gut in the newborn would be fully masked. So the question we could ask is, yes, it cannot be used for the first 7 days of life, but maybe after that, well, what this study shows is that DAO levels go in decline progressively up to 12 days of life. There, it would be seen as same level in normal adults. Of course, it takes further research, and yet I found it very interesting to share with you. And then researchers realized that DA level in newborns had nothing to do with gestational age or sex or birth weight or the type of feeding. And they saw that there was no correlation between mothers and newborns. So DAO levels in mothers and newborns are independent. This is another study from 1995, where what we see as the following. Starting feeding in preterm babies, usually preterm babies don't have a central line, so they are not in active phase when they go into feeding. So they start on day 4 or 3 of age, or there are others that are stable, but were started on feeding within 24 hours, even if they were intubated and they had lines. They wanted to see whether there were differences in DAO levels, circulating levels, measured up until 30 to 60 days of age. The answer was no difference was found. It seems early feeding in newborns would not have a protective effect. So far, there's been a summary in neonatology knowledge, which I found would be interesting to share, but I will very briefly discuss the specificities of DAO deficiency in newborns and infants. We insist that children are not just miniaturized adults. They have their own physiology, so disease shows different in them. Actually, when we talk about DAO deficiency, just the same applies. And I want to talk about histamine intolerance. You know, it's a mismatch or a balance, a disbalance where histamine levels goes up because the degradation ability in the body is reduced. In children as in adults, there are different reasons, primary reasons, what's I'm most interested in today. That is a genetic origin, as my colleagues have said before me, but there can be secondary cases where we can talk about drugs that can have DAO inhibitory effects, also comorbidity, as we see in children, such as acute gastroenteritis or celiac disease, or everything having to do with food. As for the genetic cause, I will be brief because my colleagues have done a great job at explaining it. And if I have time, I'll summarize it again, but I will skip those slides now. Let me just explain that the AOC gene, that is the DAO synthesizing gene, has several SNPs that you all know. This one here has been found in children. The enzyme that is secreted seems to have low levels of activity, and in children we've realized it has also to do with allergic rhinitis. Let me talk about food now. As you know, there is a secondary cause for histamine intolerance, which can be related to food that can be high in histamine, but we're not talking about food poisoning here. It's not that we've binged on a kind of food, but if we take rich histamine food and there is a DAO deficiency, that's what leads to a potential intolerance. When we talk about children, this is very difficult to diagnose, and it is difficult because 1% of worldwide population has some type of histamine intolerance, but only 80% of them are adults, so 20% are children, as it turns out. Question: why this lower diagnosis in children? Are we saying that children eat fewer histamine-rich foods, or are we saying that the symptoms, as my colleague said about epigenetics? So what's the role of epigenetics here? Well, if the symptoms developed by children are different. So the question we were asking up front was, what's the minimum age where histamine intolerance can be diagnosed? What's the food or what's the life of a child for an intolerance to be developed? In our literature, we see that the youngest patient is a case report published recently, and they had intolerance. It's a 15-month-old infant. It was a transitory temporary intolerance after eating strawberries, and had acute gastroenteritis. This is the youngest that I could find published. It seemed there are some authors that mention that symptoms can start as soon as 6 months of age, which lead to so many questions. Do we need to take something else, or does the breast milk have enough biogenic amines concentrated enough so that children can develop histamine intolerance? These are questions that I am sending out there. Unfortunately, I do not have the answer, but I hope in the next few years we will find the answer, all of us together. And the second topic, my last topic for children, well, histamine intolerance is very common, and we see of all the battery of symptoms that an adult might have if they do suffer from DAO deficiency, in children, symptoms might probably be different. We know that allergic rhinitis has to do with DAO deficiency, we know that it can be temporary. We know that celiac disease is also associated, but these are just a series of challenges. Common symptoms such as headaches in adults are very difficult to diagnose in children, either because they don't have it or they don't know how to put it into words. In any case, it's very difficult. So it's another challenge. Another challenge we pediatricians have trying to clarify DAO deficiency in pediatrics. These are just scenarios that can only be verified with larger cohorts. There are just few studies in children, no studies in newborns. So my conclusion to this brief summary would be precisely this, that we need so many larger studies where we see the relationship between the potential role of DAO deficiency and physiology and pregnancy and infants and children. Next, we'll move to the second half of my presentation. I'm here discussing prevalence of genetic DAO deficiency in newborns. I'm just summarize all the problems we can encounter in pediatrics. Some of the problems, rather. The question is, what can we do? How can we solve all of this? Well, my colleagues who took the floor before me have explained it, but one of the main factors for DAO deficiency is a genetic condition that is not favorable. There are many differences that have been found on the AOC gene, that it's the one that determines the enzyme, and some of which are SNPs that we know have to do with less active enzyme. 4 of them are very important. There are many other studies indicating that around 10 to 13% of global population, and you are aware, has some degree of DAO deficiency. It is unclear, though, whether it's of a genetic cause, secondary cause, and this study will be developing at my hospital for the next few months. It'll start in December this year. Well, the goal is to answer the question, was the prevalence of DAO in general population without symptoms. We're talking about genetic DAO and general population without symptoms. How many people do have those SNPs? For the study to happen, we will be working with newborns. We've thought of an N that would be 200 in healthy newborns for the first 24 to 48 hours of age. We will take samples from the mucosa, the oral mucose, to conduct this study. And this will be our prevalence study. But it's not just that. But this study has or will expand new horizons in the future. We think is very attractive because with this we will have postnatal follow-up of the children and infants, and so it will shed light on all the questions that I've asked throughout my presentation. We will even have postnatal screening. It'll be kind of a search or a screening to realize when diseases are developed. So this is a study. I hope in the next meeting that we will attend, I'll have a chance to share. This is the end of my presentation. Thank you very much. I'll be very brief. I know that there are many things that are left